안녕하십니까. 저는 경희대 보철과의 노관태입니다.
Greetings. I'm Dr. No Guante. I'm with the Kyunghee University Department of Prosthodontics. In this lecture, I'm going to talk about implant crown-related complications using some cases. Prosthetic complications, there are a variety of them, and we are going to look at some of the cases related to some of these. Crown fracture complications, crown fractures, and porcelain metal cases, porcelain fracture, chipping, connection part fractures, and there are complications associated with dentures, which will not be covered today. Hybrid metal frame fractures and complications not related to fractures. Mechanical complications from screw loosening, contact-related food impaction, and food retention due to prosthetic shapes. And some aesthetic problems in the anterior region. Overdenture, part-related problems, residual cement. This is depending on the prosthetic approaches. Displacement of a cement-type prosthesis. So there are many other complications not listed here, and we are going to look at some of these. I always consider retrievability of prosthesis because complications can occur at any time. So I always try to fabricate the prosthesis with the retrievability in mind. In the posterior region, combination type prosthesis or titanium base with a screw type. So when a problem occurs, porcelain fracture can be repaired and contact can be repaired. And if a prosthesis cannot be retrieved, I try to avoid the situation. Depending on the implant direction in the anterior region, due to the bony housing, an implant may be placed labially and a screw hole cannot be made buccally in the anterior region, so cement type is used. In this case also, when we have a problem, the prosthesis needs to be retrieved, so screw hole needs to be made using this angled screwdriver. This is the angled screwdriver, this is normal screwdriver, and this is thin. And there are many different angles. Depending on tightening angle, 20-degree angle connection can be done as well. When an implant is labially placed, lingually, we use the driver to access the site to retrieve the prosthesis. An implant is labially placed in the anterior and 20 degrees angle is used for the prosthesis. The hole is made in the prosthesis which is not visible labially. When a problem occurs, the angle driver is used to retrieve the prosthesis. This is a rather quite young patient. If you look at the implants, I did not include X-ray of implants. Implants have some bone loss around them, and there are 4 implants with severe bone resorption. The buccal dimension is quite low in terms of the facial profile of the patient. The patient is quite busy, so could not pay attention to aesthetic problems. And lower implants are planned. The patient had a very low vertical dimension. The smile line is quite low, so hardly the upper teeth are visible. We will increase the vertical dimension, and the failed implants will be removed and do prosthesis. Using the remaining implants, prostheses were planned. Explantation of old implants would be difficult, so we will use the existing implants for one-piece type prosthesis. So that is the plan. 5 implants for final prosthesis would be a little bit of a stretch. The patient would not have additional surgery in the posterior region, so immediate restoration was required for the patient. So existing prosthesis would be removed and 5 implants. One piece would be used. These are internal conical connection implants, and they are 30 degrees buccally inclined. So it's not good for one piece type combination type at the same time. In this case, multi-unit abutments can be used for the prosthesis. And these are not awesome implants, some different implants. The multi-abutment units, the angled ones, the labially positioned implants can be changed to the lingual direction. And in the process, the metal color is showing. If the smile line is high, it will be a problem, but this is not a problem for this patient. Rather than that, if a prosthetic problem occurs at any time, retrievability would be more important, so angled multi-abutment was used. These implants were decided to be removed. So titanium base is inside and monolithic zirconia is colored. They are segmented. And this is not the final prosthesis. Lower implants would be placed. In this condition, temporary teeth are delivered. The final prosthesis will be in a similar way, using this abutment so that ease of retrievability, this is my preference. If the space is sufficient titanium base, and like before, zirconia cementation would be used, but in this patient, the vertical dimension is very low. A stock abutment would be hard to use here. The patient had cancer, so it was difficult to place implants in right places. Implants were placed in the residual bone, and the implant prosthesis should be made fitting the opposing teeth. If titanium base and monolithic zirconia is used, a fracture would occur. So recently I see this kind of patients who experience fracture, and this kind of method is used. Base is tight and the zirconia thickness is not good enough. Under strong chewing force, fracture can occur. In this case, the metal is directly in contact with the abutment. Cobalt chrome metal milling is used, and on top of it, porcelain can be added on. Even though this is a rare case, but in this case, a hybrid prosthesis is challenging and monolithic zirconia is rather challenging. In such cases, this kind of method can reduce mechanical complications. The patient is using this for more than 5 years without chewing problems. We may have this kind of problem when we take impression, and usually without paying special attention, we fabricate abutment and crowns. In the process, actually, the model doesn't have a bone. On the model, only silicone artificial gingiva is included. Here there is a natural tooth, and the bone level around the implant goes down rapidly as the implant was placed deep. If this part is a little bit over-contoured, it will create irritation, causing discomfort on the part of a patient. If we carefully check the X-ray and created proper contour here, the discomfort would not have been made. But the patient complained of discomfort and the abutment was removed, and here bone was exposed a little bit, causing discomfort. So this part with the abutment, the crown was reduced at the chair side and it was polished, and the symptoms clearly disappeared. So complications like this regarding the abutment contour, aesthetic problem with the food retention is here. Problem was drastic reduction of bone, vertical bone level, and that can be solved like this. Clinically, many patients with implant prosthesis complain of food retention, and they say retained food is showing after a meal, and sometimes it is inevitable. We explain it to the patient, and they need to pay more attention to it when they have implant prosthesis. But in many cases, food retention and hygiene problem or inflammation can occur due to the wrong prosthetic shape. So let's have a look at how to address the problem of complications associated with the implant prosthesis. Clinically, I modify a lot when it comes to implant prosthesis. Implant crowns are often splinted, and the splinted part is rather thick. For implant zirconia or metaceramic, in general, the contact area is rather big compared to natural teeth. In many cases, compared to natural teeth, implant prosthesis, buccolingual width of gingiva is narrow, so food tend to be retained here. In order to food to get out of there, there should be sufficient embracer opening, lingual embracer. And upper buccal embracer should be open too. In order to food to get out, lingual embracer should have sufficient opening viewed from the top. For example, this is a typical prosthetic shapes, clinically used shapes. Number 5 and 6 are implants, and they are splinted. It is not necessary to join the crowns too thick. Compared to natural teeth, the alveolar ridge of implants is rather narrow. So for brushing and the food to go out, this part should have some opening, otherwise the food would be retained. Therefore, we always need to pay attention to the embracer opening when we fabricate prosthesis. We need to approach implant crowns a little bit different from natural teeth. I don't do a lot of implant surgery, and I see patients after implant placement, and prostheses are not ideal when they come, and if they are inclined to one side, if an implant is here and here, a lot of undercut would be created, retaining food. If implants are placed deep, the subgingival contour can be used to give some compensation. Otherwise, this part would have a lot of undercut, retaining food. Considering the implant position, the other side embracer should be modified. This is before and after the modification. On the other side of the implant, the food can be retained, so the shape of the prosthesis should be modified in this image. Tissue level implants. If there is sufficient reach and the gingiva is fat, and the tissue level implants on the other hand has very narrow neck, a buccolingual width cannot be reduced in the molar area, so buccolingual width should be provided and the food can be retained here. The solution to this is that food can come out here and through the side if we have sufficient embracer opening by reducing the contours so that food is not retained here. So it is necessary to modify the embracer. With the modification, patients, when implant prosthesis was delivered, they experience less discomfort of food retention. So this is after the modification. So this is not the way to place an implant. We should not create a situation like this. It is too much buccally positioned and the direction is not good. And the cost of abutment is compensating for the situation. But if we make a crown, food can be retained here. Fabricated prosthesis, the contour is too excessive. There's a lot of undercut and food can be easily retained, and it's hard to get rid of the food with the brushing. Buccolingual width cannot be reduced too much, so on both sides, embracer opening should be provided so that food can be coming out. With the modification of the shape of prosthesis, even though implant is not ideally placed, in order to prevent the food retention, we need to modify the parts like this depending on the position of implant without interfering with the occlusal contact or the space for tongue. I treated this patient when I was a resident. I myself made the prosthesis without sufficient embracer opening. It is all blocked and the patient's gingiva is compressed by the prosthesis. The patient didn't have pain but complained of gingiva discomfort. The patient came back after a long absence. The implants were removed. Fortunately, there was no bone loss. Perimucosal seal is not achieved. Here is the call. The gingiva is excessively compressed, so this part should be opened up, and the papilla needs to be opened up so that we can have a more healthy gingiva by modifying the shape of the prosthesis. When we design prosthesis, we try to fill the papilla area from the beginning, but that area needs some breathing space. The embracer should be symmetrical with the adjacent teeth over time. The gingiva should be settled in that space. So for that part, considering the adjacent teeth, the papilla space should not be blocked too much. So at the beginning, some space should be provided. Over time, papilla would creep up along the contour to a certain degree. So rather than trying to block the papilla space from the beginning, you need to have some opening there. I'll show you how I modified the prosthesis in this patient using a disc. This part was modified. The embracer was opened. Buccal and lingual embracer was expanded. The contact area with the natural tooth, the contour was reduced so the papilla is not pressed down. After such modification, within a couple of weeks, the gingiva would be settled. In the posterior region, the contact with the adjacent tooth, it is about 1 millimeter below the contact continuing from a premolar. Above it, I try to keep it open. In a case where a crown is much longer than this, I do not provide a contact up to the part below. The contact is created just a little bit lower than natural tooth. To facilitate brushing, about 2 weeks later, gingiva is creeping up and I think I should have opened it up a little bit more. There is a gingiva recession quite a lot and the crowns are long. Rather than blocking the space, peri-implant mucosa seal should be maintained and the contact is formed just below this line. For the rest, we just wait. By maintaining the situation, we just wait. About 5 years later, and after about 6 months, these are naturally filled. Over time, a little bit of a recession occurred, but they are used without a problem. At the beginning, if we try to block the embracer too much, it would be not very good. So we need to provide a breathing space. Especially when an implant is placed shallow, we need to be careful. When they are placed too shallow, it is unfavorable for biologic width and which is vulnerable for additional bone loss. Rather than trying to expand the peri-implant mucosal seal, a sufficient embracer space should be provided. That is the right approach for providing prosthesis. When an implant is placed too shallow, if you provide too excessive contour, like in this prosthesis, that will create a gingiva problem and that will lead to bone loss further. In this case, instead of expanding gingiva, the embracer is sufficiently opened and controlled so that food below can come out at the occlusal side. The prosthetic form, it would be unfavorable for biologic width. Functionally, it would not have any problem long term when an implant is not positioned placed correctly. Today, I talked about the various prosthetic complications, especially prosthetic contours, and how to secure prosthetic stability. I will see you at the offline course. I want to share with you crown contact related complications, porcelain fracture complications. Thank you for your attention.